Good morning, everyone. I'll present on behalf of Medicine One. My topic for today is hitting the bullseye. Presenting a 66-year-old lady who presented to us from Chennai with history of inflammatory polyarthritis for 2 months. She presented with initially a left knee pain with swelling with limitation of her daily activities, which restricted her walking. Subsequently, she developed pain in the right knee, bilateral hips, ankles, shoulders, elbows, and wrist involvement. There was no involvement of her toes or her fingers at all. This was associated with swelling of bilateral knees and ankles, and she had an early morning stiffness of around 30 to 60 minutes. She also noted severe myalgia of her bilateral upper limbs and her calves. For the past 10 days prior to presentation, she also gave history of low-grade fever, but there was no history of chills or rigors, and there was no history of any diurnal variation. She did not have any fatigue or night sweats. She reported an intentional weight loss of 4 kg for the past 4 months. There was no history of headache, vomiting, blurring of vision, red eyes, oral or genital ulcers. There was no history of painful micturition or any inflammatory back pain. She did not report any skin rashes, any altered bowel habit. There was no history of cough or any features suggestive of an autoimmune or connective tissue disorder. She noted that there was some occasional tingling sensation and numbness over the dorsum of her feet for the past 2 months, but there was no history of slipping of sandals while walking. Past history-wise, she was a known case of dyslipidemia and a degenerative disc disease for which she was on physiotherapy and lifestyle modification. She had noted allergy to aspirin and sulfur drugs. There was no history of contacts with animals or pets at home, and there was significant travel history to the USA for the past 3 months before she came to us. So she was in USA for 3 months, 2 months prior to the onset of the illness. On examination, her vital signs were stable. There was pallor present. There was no icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. She did not have any skin rash that was noted. There was no oral or genital lesions. There was no cutaneous markers of malignancy, infective endocarditis, or tuberculosis. Systemic examination of cardiovascular, respiratory, abdomen, and CNS system was normal. There was no objective sensory or motor deficits on examination. Musculoskeletal examination wise, she had a swelling which was noted at inspection at the right knee and bilateral ankle joints, but there was no erythema or deformities of any of her joints. On palpation, she had tenderness in the posterior aspect of the right knee with swelling, but no warmth, and there was no effusions noted. Her range of movement, active and passive, at all joints were normal. There was no features of enthesitis or dactylitis, and her Faber's and modified Schober's tests were negative. So I would like to call for any differentials from the audience.
You go another 10 seconds. All right.
So, a syndrome was that of a non-deforming large joint predominantly, which started as an asymmetric but later became a symmetric inflammatory polyarthritis with constitutional symptoms. Anatomical localization was that to a musculoskeletal system with the probable inflammation. The etiological diagnosis that we thought was first of a polymyalgia rheumatica. Other things that we considered was peripheral SPA, SLE or Sjogren's, or an adult onset Still's disease. When it came to infections, we were thinking of whether it was tuberculosis, viral arthritis secondary to HIV, hepatitis C, syphilis, brucellosis, or because of a history of travel to US, whether it was Lyme disease. We also thought of sarcoid arthropathy or crystal arthritis or a paraneoplastic arthritis as well. Coming to investigation, she had a microcytic anemia, which was later found to be iron deficiency. Her LFT showed an elevated alkaline phosphatase of 217, but gamma GT was normal. Her inflammatory markers were elevated. CRP was 98. Later, it came to 120, and her ESR was elevated as well. Her blood-borne screening was negative. Her ANA was 1+, but other markers with rheumatoid factor, anti-CCP, dsDNA complements were all within normal limits. Her calcium was normal and the ACE was normal. Her ANCAs were negative. She did not have any hyperuricemia. We did an ultrasound musculoskeletal which showed bursitis at bilateral shoulder joints with features of tenosynovitis and AC joint arthritis. Her temporal artery Doppler was normal. Her PET CT showed diffuse uptake noted in bilateral shoulder, wrist, hip, and knee joints. NCV was done, which showed a mild sensory motor distal axonal neuropathy. We do not have Lyme serology in our hospital, but we outsourced it to a laboratory outside, which showed both IgG and IgM positive in her case. So our final diagnosis on her was a post-infectious Lyme arthritis with sensory motor axonal neuropathy with an iron deficiency anemia and dyslipidemia. So what I would like to focus on is Lyme disease and its manifestations and the prevalence of this disease in India. So Lyme disease is the most common vector-borne disease which is found in the USA. However, it's also reported from Europe and Asia. It's caused by spirochete Borrelia burgdorferi, which is Borrelia is currently renamed as Borrelia. It's transmitted by ticks of the Ixodes ricinus complex. So in USA, it's Ixodes scapullaris. In Europe, it's ricinus, and it's in Asia, it's Ixodes persiccatus. The tick goes through a cycle of from the eggs, there's larval stage, nymph stage, and then an adult. Nymph stages, which is most likely to cause human infection, and the duration is around spring and summer months. The presentation can be divided into early localized infection, disseminated infection, and late onset disease. It's not necessary that the patient presents consequentially in one of these stages. It can actually present at any stage, or there may be overlap between the stages. So the first stage is where they have skin manifestation, that's erythema migrans, which is typical of Lyme disease, which is what looks like a target sign or a bullseye, where you have erythematous margin with a central clearing and a center reddish area, which is like a target sign. Then they can also have, in the acute later disseminated phase, they can have neurological manifestations with severe meningoencephalitis or multiplex, mononeuritis multiplex. In the later stage, they present with arthritis, which is classically an asymmetric oligoarthritis to begin with. However, later they can become generalized symmetric arthritis as well. So in 60% of untreated patients, actually the presentation is that of a late arthritis and Lyme disease. And the most common involved joint is supposed to be the knee joint. Peripheral joint involvement of small joints of hands and feet are very unusual. The diagnosis is actually very challenging because the serologies are not standardized over the world. The gold standard is isolating the organism in culture, but that's very difficult to grow. And PCR from any synovial fluid or any CSF if it's available. The most commonly used testing is two-step testing with an antibody response test by ELISA and Western blot. Treatment depends on the disease involvement. So if there is carditis or a neurological involvement, IV ceftriaxone is warranted for a period of 4 to 6 weeks. However, if it's only arthritis or skin manifestation, oral doxycycline for 28 days to 2 months is indicated. And most patients have good response to the treatment. Coming to Lyme disease in India, actually the data is very limited. There have been instances where they have reported the vector in India. So Ixodes ricinus and Kashmiricus has been reported in Himalayan areas with infestation in domestic and wild animals. There have been reports of certain neurological involvement with the meningoencephalitis from areas of Haryana, Himalayan belt, and northeastern areas. There was a report of neuroretinitis secondary to Lyme disease reported in South India. However, diagnosis in this case series was not clear. They have also reported an outbreak in Kerala in 2013 because of carrying the vector by deer population, and that reported one death as well. So in our patient, we started on doxycycline 100 mg twice daily, and with started her on physiotherapy and pain relief as well. At 1 month review, she had symptomatically improved. Her inflammatory markers were normal, and her ALP had also reduced. So my take-home message is importance of travel history and epidemiological knowledge of different infectious diseases, and Lyme disease and its manifestation and its current importance to us with prevalence in India. Thank you.
Well, Sakshi, that was a good diagnosis and nice that you chased the history and got the testing also done. Usually, reactive arthritis is the fever is gone and then the arthritis appears. Did she have fever at the time when she had the joint pain in the admission?
She started having fever a little later into the illness, sir. At the time of presentation, only for the past 10 days she had fever. But it was all low-grade fever. The maximum documented temperature was 101.
So she had fever at the time of joint pain. Did you do an aspirate of the joint? And
there were no effusions to aspirate, sir. Okay. There was only features of some bursitis, but no joint effusion to aspirate.
Okay. Questions from the audience?
Very good case. Sakshi, I have 2 questions for you. So, what is the diagnostic method the lab used?
Ma'am, it was ELISA. Basically, actually, the ideal way is to confirm it with a Western blot, but the lab service didn't provide that. It is it's outsources to New Delhi. So there, what they do is they have IgG and IgM titers, and they have set points for both, standardized points for both. And if the IgG and IgM both are in high titers, that's when they consider diagnostic for Lyme disease. If the problem with Lyme disease diagnosis is the IgM can remain positive for a very long time. But the titers, the value will tell you whether it's actually an infection or just the seroprevalence of the patient. So in her case, both were very high.
Because usually if you do only antibodies, we'll have to see an increase in titer.
We've not recent sample, ma'am.
Did the patient have this?
No, ma'am, no. She had history of, in the US, when we clarified, she actually went to areas which are tick prevalent. So she went into North Carolina and she had multiple trekking trips that she had undertaken. So we thought that was a very likely possibility in her, given the clinical plus the exposure history. And she had also received steroids outside, but she had not responded to the same.
Any other questions? We have one more presenter.